the issues that you'll be having. Yeah, so urinary infections, infections at the sites, wound infections, and so on. Yeah. And then between 1 to 2 months, then you start having a bit of the activation of latent infections. So patients who've had infections that are sitting down, well controlled, but then because of the immunosuppression, they start coming in, opportunistic infections, and as your patient is going home, a lot of the community-acquired infections, so listeria and so on. Yeah? If you look at your viruses, again, a lot of the donor-derived viruses, a number of them are setting early, though, I mean, quite a number may set in while the patient has actually gone back into the community. So, for microbiologic assessment for us, from our end, other history, there's a lot that the doctor does to read the risk that this patient has. After that, then we would go to what kind of assessments that you do. And majority, most of the time in our setups, you'll find that we're looking for the triple serology. You're looking at HIV, hepatitis B, hepatitis C. Then you'd add on, onto that. Yeah, you'd add onto that the risks that you're looking at. This is derived from international guidelines. So again, there are guidelines and setup-dependent guidelines that test one, versus the other. So CMV, IgG, IgM, and some of the setups in the West would actually go ahead and test the herpes viruses, we test the EBV viruses and so on. For EBV, we actually, most of the time, we test the viral capsid antigen, and we may add either the early antigen or the nuclear antigen to it. Yeah. For the measles, mumps, and rubella, there are setups that actually have that as a standard part of setting. For our setup, this is not routine. We don't test either the EBV or the mumps, measles, and rubella routinely in our setup. But in some of the setups in the West, they actually have that, and they use the serology IgG, IgM kind of testing in these patients. Syphilis, treponemal and treponemal testing. HIV, most of the time, what is available in most of our setups are the 4th generation, and that is what is recommended. If there is any issues, then beyond that, then you have to either go for molecular-based kind of testing. Yeah. For hepatitis B, other than the hepatitis B surface antigen, if it is suspected to be positive, most of the time you would go ahead and do your nucleic acid amplification test, your molecular test. For hepatitis C, we do the hepatitis C antibodies, and if positive, then you would actually go ahead and do the nuclear amplification test. Now, some of these tests are not meant to entirely exclude patients. It depends on the kind of setups that you're working in, but more of management. How then do you manage these patients when you know they are positive? How do you go ahead and manage these patients? Some time back, if you're hepatitis B positive, hepatitis C positive, HIV, even HIV positive, it would strike you off, transplant list and so on. Right now, the guidelines are coming up in terms of management of some of these patients. Of course, some of these are dependent on sites. TB testing, a lot of the people would want to know whether you're having want to know whether it's something to worry about once he starts you on anti-immunosuppressants. And you'd be surprised, there are setups that go all the way, and as I say, they will actually even test these herpes to varicella zoster. They would be worried about that, and staphylococcus and fungi like seen in the US. But most of our setups, the setup like we're working in KNH, most of them assessment, hepatitis B, C, HIV, we will do urinalysis, infections that are setting in. Most of the time, that's where we would stop. Now, for the kind of testing that we have, majority of these tests have been on serological platforms. So that means we're able to do IgG, IgM on them. But there are newer tests, like the molecular tests that are coming in, and a number of guidelines are starting to shift towards molecular testing for some of these. For the serologic assays, the IgG generally detects either chronic or persistent infection or a past infection. The IgM most of the time would be able to pick up more recent infections. This is before transplant, before immunosuppression. You will see that the situation after immunosuppression is slightly different. And of course, they have their own issues, when it comes to serological testing. The seroconversion will take time. Patients desert what is called the window period and so on. And you see that even our HIV test, the 4th generation assay, has been improved because of the addition of an antigen component to it. It's no longer just an antibody testing. The antigen is actually closing down or narrowing down the window period in which you're able to get a positive test. But as I said, majority of people are now moving to the molecular test. Now, because we're talking about infections, most of the time, and we say that majority of them are actually surprisingly the bacterial infections. How good are our labs when it comes to cultures of the specimens that are being submitted? Yeah? Most of the time, you find that majority of our labs in the region are basically just doing manual tests, may not be able to do much in terms of doing an identification and getting antibiotic susceptibility testing. Our bigger labs are able to do with the conventional and biochemical test and able to do, identification and susceptibility.
You can put on the slide.
Dr. Blanca?
Help us with the... So, good evening, all of you. How many of you are clinicians here, working for doctors? Okay, at least a few. Okay. How many of you have dealt with the transplant patient? Family member, relative? Excellent. Most of you work in the lab. Oh. Good. I'm consultant physician and a kidney specialist working at the Knbts hospital. I'm actually in charge of the kidney transplant unit, which is what I have. And I'll be talking about infections post-transplant. As my colleague said, we were going to talk about innovations in infections post-transplant. Now, this is a very difficult topic, unfortunately. So I opted to go for infections post-transplant, and half of my work has been done by Dr. Kasim because he talked a lot about what the clinician is supposed to talk about. So thank you very much, Doc. But it was a very difficult topic. So when you look at kidney transplantation, our first successful kidney transplant was done in 1954. And from then on, it has been an upward trajectory of the number of kidney transplants. The kidney is the most transplanted organ if you look at the history of transplantation. And if you look at this slide here on the right, you can see that the overall incidence of acute rejection rates are actually on the decline in the first 1 year. So graft survival in the first 1 year has significantly improved, and now we're getting a graft survival of more than 90% in the first 1 year. However, if you look at this slide on the graph on the right, on my right, this is basically the ENDS data, which is basically New Zealand and Australian data, which has been clustered in years. And you can see that up to the point of 2006 plus, the 10-year survival rate basically is very dismal, okay, when it comes to graft survival. So graft survival for the short-term period or the acute graft survival is very good. 1 year survival, we have got more than 90%. However, if you look at the 10-year, 20-year survival, we're actually hitting less than 50%. So we're losing the grafts on the way, okay? So what is the most common cause of loss of the graft? The most common cause of the loss of the graft is basically chronic infection, okay? The second most common cause is mortality. So patient who has graft actually dies and goes down with the functioning graft. And what are the most common the most common is cardiovascular disease, followed by infection. Infections is 20%. Infections forms a very common cause of mortality in these patients. Remember, we are giving this patient initially from 1954 all the way to 1990, the 1 year survival was very poor because of the fact that these patients were rejecting. So we got more and more potent immunosuppression. Now, of course, there's the immunosuppression, isn't it? You are immunosuppressing the immunity completely for these patients. These patients can pick up any infection. As well, you can pick up a common cold, and this common cold can actually kill a transplant patient in the first 6 months, because these patients are on very suppression. The other collateral damage is malignancy. We are putting these patients on immune stimulators, okay? Alpha inhibitors, they are those that basically inhibit your cellular immunity. Remember that the cellular immunity is very, very important and key when it comes to fighting malignancies as well, okay? So this is the reason why we're getting very high incidences of mortality in these patients because of infections and malignancy. So when you look at the basic principles of infections in an immunosuppressed patient, here you have a patient who has been given a foreign body. Suppresses his immune system to make sure that that graft survives. Okay? So you're going to give him heavy doses of immunosuppression. And what happens? In case he gets an infection, one is that it is going to be a virulent infection. Most likely it's going to kill him. He will not be able to mount the classical immune response. Okay? He won't get the classical fevers, he won't be sweating. Okay? So the heavy immunosuppression may abolish the typical signs and symptoms of the fact that you are suppressing the immunity. Dr. Kasim rightfully put it that for cytomegalovirus, there is delayed seroconversion, okay, because of heavy immunosuppression. So these patients may not be able to give you, will not be able to seroconvert, like for example, when they get cytomegalovirus infection. So the cytomegalovirus IgM has got a very low sensitivity. So they have decreased sensitivity of the serological and the radiological tests. Now, when that happens, and the patient is already having a smoldering infection, and you're not treating it, suppressed, the effects of the established infection may be very devastating, and this is what eventually leads to mortality. Okay? Remember treatment. Yes, we do have wonderful treatments for this infection. If you have a fungal infection, we can put you on amphotericin B, isn't it? We can put you on azoles. Now remember, when we put you on amphotericin B, it's going to knock out your kidney because amphotericin B is very nephrotoxic. So these drugs have collateral damages as well. If you get TB, we put you on a rifampicin-based regimen. Rifampicin has a drug-to-drug interaction with your tacrolimus and cyclosporine, your calcineurin inhibitors. It reduces the levels. Erythromycin and azoles increase your calcineurin levels, which leads to toxicity for the graft as well. So either way, we have to be, if you use medications and after the patient gets an infection, even after you pick it up, you can see that the patient may also get more morbidity from the drug itself that are using to treat the infection. Okay? So infection in transplant recipients is basically the net state of immune suppression and the epidemiological exposure. Kasim touched on the net state of immunosuppression. So what exactly is meant by the net state of immunosuppression? So the net state of immunosuppression is a semi-quantitative assessment that we do of all the complex interactions of the factors that basically increase the risk of the patient getting an infection. So what are these factors that we're talking about? These factors include, one is the dose of the drug that you are using, the duration of the drug, the temporal space that you're using for the drug that you are giving, and whether you've given any medication to treat rejection. Okay? The type of drug that you have used for your induction therapy or your desensitization therapy or treatment of rejection and subsequently maintenance therapy. Remember, we have very fancy drugs now. We have the lymphocyte depleting drugs like rabbit antithymocyte globulin or ATG. We have alemtuzumab, which is also lymphocyte depleting as well. Now, these drugs basically deplete your lymphocytes, and these can basically predispose you to getting viral infections. Then we have those drugs that are going to affect your antibody responses, like the rituximab and bortezomib. Okay? So we have those two factors that basically increase your immunosuppression as well. Then remember that the patient themselves can be having a net state of immunodeficiency, like they can be having a leukopenia because of their basic comorbidities. They can be having a thrombocytopenia as well. There's an aspect of surgery whereby there's breach of the skin and soft tissues. Okay, you're putting in foreign bodies like catheters, ureteric stents as well. The patients have comorbidities like diabetes, so they have a background of hyperglycemia as well. Now, all of these basically increase your net state of immunosuppression. And this predisposes these patients to getting infections. How about the epidemiological exposure? So where do these guys get the infections from? So it can either be donor-derived infection, okay, like what Dr. Rastum talked about. So these patients can come in and infect the person with the cytomegalovirus, with human herpes viruses like Epstein-Barr virus. Epstein-Barr virus is very important and has to be tested. Okay? In our facility where we do transplants, it is mandatory to be tested for EBV, because if you transplant somebody who is EBV, if the donor is EBV positive and the recipient is EBV negative, the risk of getting post-transplant lymphoproliferative disorder is very, very high for the first year of transplantation. So we do test for that as well. Varicella zoster. It is mandatory for us to test in our policy. We have had instances whereby the donor is positive and the recipient is negative for varicella zoster IgG, meaning that the recipient never had the varicella. Now imagine if you would have gone ahead and transplanted and suppressed the individual, and now he already has the virus. It could have caused catastrophic consequences, isn't it? Okay? Then we look at the recipient-derived infection. The recipient himself could be having HIV. He could be having latent cytomegalovirus, latent Epstein-Barr virus, latent TB as well. And we pick up cases of TB, we pick up cases of hepatitis B as well in these patients. Then there are those infections that actually come from the community. Okay? Once when you immunosuppress an individual, and especially now in this era of COVID-19, I've had patients post-transplant coming in with COVID-19, unfortunately, after the transplant. Thankfully, majority of them have been able to get out of COVID. We have lost 1 or 2 patients, unfortunately. And it's a real threat out there. And because of the COVID-19, we had to change our policy and include COVID-19 testing both for the recipient and the donor just prior to the transplant as well. Then there's the nosocomial infections that are there as well. Okay, Dr. Kasim has talked about. So we know that when a patient is undergoing transplant, especially for a living donor program, we have enough time now to look at the patient holistically. We have enough time to look at the donor as well. We know what pathogens we want to cover as well. So we know what kind of prophylaxis we can give. So we can give these patients prophylaxis. We can give them antivirals post-transplant. We can give them Septrin, okay, post the transplant to prevent or reduce the incidence of PCP. We give them more potent immunosuppression as well. With the more potent immunosuppression, as I told you, we know which arm of the immunity we are suppressing. Is it the cellular immunity? Is it the antibody-mediated immunity? So with that, we know exactly what type of pathogen we are going to be getting, what prevalence of pathogen we'll be having. Because of all of this, these patients will basically present with a modified presentation, isn't it? They won't have the classical symptoms, okay? The timings may also change as well. I'll also show you a very similar chart to what he has shown about estimated timings for these particular infections. Now, when you're using widespread prophylaxis, in South Africa where I trained, we used to give TB prophylaxis as well for 6 months, isoniazid prophylaxis. Again, the question that comes in is, what is the risk of resistance setting in for these patients? Okay, Septrin prophylaxis for 6 months, what is the risk of resistance setting in? Antifungal prophylaxis, what is the risk of resistance? Okay, so all these are the questions for which nobody has answered, but we still practice it because studies have shown that giving prophylaxis is much better and helps to improve mobility, reduce mobility and reduces mortality as well. Okay, so these are the usual sequence of infections post-transplant. Remember, usual, but these patients have a totally unregulated immune system. Okay? In the first 1 month is basically the nosocomial infections and infections related to the surgery or the complexity of surgery. You might even have to take the patient in for a relook, increasing the chances of infection. So in the first 1 month, you basically have a higher incidence of getting bacterial infections, fungal infections, especially Candida. Okay? Between 1 to 6 months, these are your unconventional and or opportunistic infections. After 4 weeks is when now if all of your immunosuppressive drugs have kicked in, they've achieved the target levels that you want, optimal levels, you have thoroughly immunosuppressed your patients, and this is whereby your opportunistic infections come in. Things like pneumocystis, urethra pneumonia, aspergillosis, cryptococcus, your immunomodulatory viruses, your herpes viruses. Cytomegalovirus is an immunomodulatory virus, and we're going to talk more about it. Okay? Epstein-Barr virus, varicella zoster virus as well. Okay? But once when the patient has hit 6 months and everything has been safe, we call that a stable graft function, meaning that now the patient is past that acute phase whereby the risk is much higher. Okay? But again, you can still get infection at this place as well. Okay? You can get BK viral nephropathy at this point as well. BK viral nephropathy, the risk is highest in the first 2 years. Okay? If the patient starts rejecting here because of non-compliance and you put them on anti-rejection medications, you can go back again to this side and you can get all this infection. The risk goes up much higher. Okay? So I'll touch on the BK virus because we are now finding it more and more commonly in our setup. Okay? BK virus is a polyoma virus. We have more than 32 polyoma viruses. BK virus is one of them. We have the JC virus, I'm sure all of you know about it. For those of you who do clinical medicine, the SV port is also another example of a polyoma virus. So the BK virus basically is a circular double-stranded DNA virus. There are 6 subtypes of the BK virus, and BK virus is very ubiquitous. More than 80% of adults, even here, are positive for BK virus. BK virus is acquired in childhood to the respiratory tract. Okay? Once the body takes care of it, it basically undergoes, goes into a latent phase, and it attaches onto the urothelia and the renal tubular cells. Okay, so this is where it resides. Once when you start immunosuppressing the patient, and there are certain risks, certain patients who are at a higher risk, like for example, if the donor was seropositive, okay, or if you use very potent immunosuppression, the recipient is seronegative, the recipient is a male, we use a ureteric stent. If the HLA mismatch was much higher, the polyschema time was much higher, if the patient had a subtype 4, then these are basically patients with high risk factors for developing BK viral nephropathy. Okay? As I told you that the time span is basically the first 2 years is the time in which it is the most common to get the BK viral nephropathy, but it can go up to 5 years. Okay? And this is the natural history of the BK viral nephropathy. Okay? You get epithelial injury, it leads to myuria, meaning that the virus is being shed in the urine. Then it leads to viremia when the virus is now present in the blood, and subsequently it basically causes damage within the graft, what we call BK viral nephropathy. So it can cause anything from hemorrhagic cystitis to ureteric stenosis to urothelial malignancy and tubular interstitial nephritis. Now, up to 30% of patients post-kidney transplant do tend to get a biuria. Okay? Out of 10% can progress on to develop a BK viral nephropathy. Okay? The risk of rejection with BK viral nephropathy is very high. 10 to 30% of patients who get BK viral nephropathy will tend to reject, because the main treatment of BK viral nephropathy is reduction of immunosuppression. We have to reduce the immunosuppression so that the body's immune system can basically take care of it. BK virus is also immunomodulatory, so it is going to upregulate the immune response, and subsequently, because of the upregulated immune response, those immune cells can also target the foreign proteins which is found in the kidney, and it can lead to increased risk of rejection. Okay? You need a biopsy to confirm the BK viral nephropathy. Okay? The management of BK viral nephropathy for patients who are at high risk, we basically tend to monitor them after the first 1 month and then 3 monthly for 2 years. You can do the decoy cells in the urine. The decoy cells basically you do it on the second urine specimen of the day. It is fun. Basically you look at the cells in the microscope of the urine. It has a low sensitivity but a very high specificity, but more the preferred method is basically doing the PCRs. After 2 years, the risk is much lower, so then you can do it yearly for another 3 years, and then you can basically stop. Okay? Biopsy is not routine unless if the creatinine rises. If you have a positive result for a BK virus, like if you get BK viremia, then you need to reduce your immunosuppression. So the first thing to do is to basically reduce your CNIs, which is a tacrolimus or cyclosporine. Preferably stop your mycophenolate, which is an antimetabolite, and switch them over to an mTOR inhibitor like everolimus. You may convert the tacrolimus to cyclosporine because tacrolimus is much more potent than cyclosporine. and you need to monitor that for the viremia. If there's no response, you may use the intravenous immunoglobulins, because it is thought that these immunoglobulins will basically take care of the virus. Okay? The other one I'm going to touch on is the cytomegalovirus. A double-stranded DNA virus. The prevalence is more than 60% in the adult population. It comes from the herpes virus family. It belongs to the herpes virus. It's the herpes virus 5. This is the cartoon of it. Okay. So, majority of the patients, majority of adults basically already have primary